All right, in this segment, we're going to be covering ventricular rhythms. Now, ventricular rhythms are electrical firings that stem from the ventricles and not the atrium where it's supposed to. Right, so instead of the SA-AV node, this is firing around the bottom, which is the bundle of His and Purkinje firings, and firing round and round in circles. The first thing we're going to talk about is ventricular tachycardia. That's more of a uniform type of firing. It fires over and over and over in a straight line or round and round, and is presenting to you as this. As you can see here, the main things that we find is there's no P wave, right? No P wave, no discernible P wave at all. Or as you can see here, it starts as a P, but then it becomes undiscernible. The QRS is very wide because QRS is that ventricular beat, and that's all you're seeing there. And of course, there's no T wave at all. You can't see that at all because it's completely overlapped by the other QRS waves. So biggest thing that you got to note down is the treatment option for this. So ultimately with ventricular rhythms, we got to shock. All right, we have to shock. Which type of shock is going to be dependent on the rhythm. There is a rhythm right here, right? As you can see, there's a repetitive rhythm. We got to synchronize our shock to return this rhythm to the patient. So the type of shock that we'll be providing is what we call a synchronized cardioversion. We got to aim for those top of those R's, shock that back into the regular rhythm. Now, depending on how this patient looks, most of the time this patient is going to be pulseless. If not pulseless, we have to synchronize cardiovert. If the patient is pulseless, we got to start CPR, start our compressions, and then ultimately the only fix for this is going to be that synchronized cardioversion. Now, another type of ventricular rhythm we have is ventricular fibrillation. Now, for that ventricular fibrillation, there is no uniform firing. The whole entire ventricle is just firing at random, meaning there's no discernible rhythm. No P wave, no QRS, no T wave. If there is no discernible rhythm, right, we cannot synchronize that shock. We can't shock it like we did ventricular tachycardia. We just got to send a random shock, which is what we call a defibrillation. Another easy way to remember that is VFib, defib, right? For ventricular fibrillation, we defibrillate. Defibrillation, the key words there, defibrillate, right? So no discernible rhythm here. This patient is going to be pulseless. We will have to do CPR, and we do CPR, and the ultimate fix again is going to be that defibrillation. All right. These are called PVCs, just the ventricular rhythm, ventricular beat, right in between two different PQRST waves. As you can see, that single PVC here, these are called bigeminies, where it happens over and over every other beat. Now, NCLEX will not really go too in depth with the PVCs, but for your own clinical practice, one big thing that causes PVC is an electrolyte imbalance. So we want to maybe get some labs there. Now, let's talk your cardiac arrest. This is a straight asystole, or most likely a straight line. There is no electrical impulse. I'm not a fan of your medical shows. My students know this. I'm not a fan of medical shows because the moment they see asystole, what do? They shock the patient. All right. The equivalent of shocking an asystole patient is the equivalent of throwing that heart and treating it like a piece of steak and shocking it with a car battery. Is that piece of steak going to live? No. There's no electrical impulse to begin with. Shocking is only effective if there's an electrical impulse. There is no electricity in this area. Shock is not going to fix this. Do not shock the patient. We must do CPR. CPR is the only way to get our patients back, right? CPR. So PEA, what is a PEA? PEA means pulseless electrical activity. If you discern that word, meaning there's electrical activity, but there's no mechanical beat. It has to be two, right? It's basically comparing it to a car. The battery's working, but the engine is dead. Yeah, the battery's working. You turn on that car, you can see the lights, but there's no engine running. That is what a PEA is. So what can we do? For a PEA, usually depending on the rhythm, right, we don't shock it. We don't want to get rid of that wave. It has an electrical wave. It has an electrical impulse. We don't need to shock it, but we want to do CPR, meaning if you do CPR and somehow you jumpstart that mechanical beat of the heart and matches it to the electrical rhythm, we can somehow probably get that back. And that is the key there. All right, this is called torsades. Torsades is a waveform that looks like a giant waveform that goes smaller, bigger, smaller. It's like in a peristaltic type of waveform. If you see this in the peristaltic motion, just remember the only fix is magnesium sulfate, IV magnesium. That is it. That's your main answer there. Now, we talked about your MIs in one of my segments right there, but let's look at what an MI would look like in your EKG. So we have two types, right? We have two types of MI. We have the stable versus unstable. Angina, sorry, unstable versus unstable. We're talking about your unstable angina, which is your MI. Two things can happen. We can have what we call an ST elevation versus an ST depression. That ST segment either goes up or goes down. If the ST segment goes up, that just means that there is necrosis, there's cell death, there's tissue death. ST depression, on the other hand, means there's hypoxia. So, which do you think is worse? The cell death, right? ST elevation is usually our bigger problem. Here's another example of how you might see that on the leads. On a 12 lead, it is protocol that we must find this on two different leads to consider it an MI. And this is what we call ST depression. Okay. So placements for your CPR, for your pads are gonna be this upper left. As we try to encompass that heart, we try to sandwich that heart and shock it that way. For pediatrics, it's just front and back. Okay. And this is what it will look like in a clinical setting.